Hi everyone, it's Hunter Hicks. Today we're going to look at some antibiotics. Very basic, but let's cover them. So first, talk about penicillin or the penicillin family. So really these medications and cephalosporins and some other antibiotics are what we call these beta-lactam rings, meaning the actual structure of them is made up by these beta-lactam ring. And when we look at that, there are things that can break them down, like beta-lactamases. So these are released by bacteria that actually cleaves that beta-lactam ring and makes these antibiotics not work as well. So that's really where it comes from. Obviously, it's the structure, but then also we get this resistance from it as well. Now, in general, penicillin, how they work is they weaken the cell wall. Well, if you look at the cell wall of bacteria, they have high osmotic pressure within the cell, meaning they have high pulling pressure. So if we weaken that cell wall and open it up, all that fluid is going to run in, which causes the cell to kind of swell and then burst open, which is relatively how this works. Now, penicillin is going to work way better for gram-positive than it is mostly for gram-negative, depending on the certain type of penicillin medication. And the reason for that is that the gram-negative bacteria have 3 walls, and they're a little bit more rigid than the 2 walls we see in gram-positive. Now again, resistance is going to be from these beta-lactamases. And if they're resistant to penicillin itself, we call these penicillinases, which we'll look at cephalosporins, but actually kind of see the same thing here. Now MRSA is a very interesting one. In general, penicillin had an issue, or I should say the Staph aureus was very resistant to penicillin, and still is pretty much. Well, Staph aureus was resistant to penicillin, so a long time ago, back in the, I don't even know exactly when, they came out with methicillin, which is obviously just an older med now. Methicillin was able to kill off all this Staph aureus. However, just like Staph aureus became resistant to penicillin, it actually became resistant to methicillin. And then there was a big group of bacteria that did that. Now we call these methicillin-resistant Staph aureus, meaning it originally came from all these bacteria just being resistant to methicillin, an older penicillin we used to use, and now we just see that there's just really these bacteria, MRSA, we commonly call it, that is resistant to majority of our penicillins out there, cephalosporins, and then obviously methicillin. When we look at penicillin, there's different kinds of groups we can use. We have our narrow spectrum, which are penicillinase sensitive, meaning if the bacteria releases those beta-lactamases or penicillinases that break down that beta-lactam ring, it will render these medications inoperable. They won't work as well. So narrow spectrum like penicillin G or V, again, basically good against gram-positive bacteria. Penicillin G, sometimes commonly used in syphilis. Narrow spectrum or penicillinase resistant nafacillin, great example here. Now he has a narrow spectrum, which means you can't really cover a ton of bacteria, but he's good for the bacteria that is trying to be resistant or destroy penicillin, like staph that produce penicillinase. Staph aureus, Staph epidermis, nafacillin is going to be better for those bacteria that are resistant to penicillin. Now, broad spectrum, we have ampicillin, we have amoxicillin. So we still get that good gram-positive breakdown from ampicillin and amoxicillin, but we also get some gram-negative coverage here because we're getting a broader spectrum. Extended spectrum, so even more, is going to be our piperacillin. Now, in general, when we look at the adverse reactions to penicillin, the most common is going to be allergies. Penicillin is actually one of the most common medications to cause allergies than like any other med out there, right? So up to 7% of people will have a penicillin allergy. Now, that doesn't mean that allergy is always going to be anaphylaxis or really bad. It can be totally mild all the way up to really severe. The other thing is the timing of that allergy. Some are immediate, right away, accelerated or even delayed up to days and weeks later, making this very tricky. Now, patients obviously need exposure to penicillin for it to be a true allergic reaction before they have the allergic reaction, but that allergy can actually go away or diminish. That's why it's always good sometimes to try skin tests again and see where your patient's at. Obviously, doing this very carefully. If your patient has a history of anaphylaxis, I'd be very careful trying to do a skin test here. Now, there is a 1% cross-reactivity to cephalosporins, meaning if someone's allergic to penicillin, there's a 1% chance they're also going to be allergic to cephalosporins, who also have a very high adverse reaction of allergies as well. Now, the idea here is if you have a mild allergy to penicillin, it might warrant the ability to go on a cephalosporin. However, if that allergy is severe, anaphylaxis or something like that, then cephalosporins are also not a good option. Now, the good thing is, we talked about beta-lactamase, and beta-lactamase is what breaks down the penicillin, and it's the bacteria that are resistant to penicillin. Well, the good thing is we have beta-lactamase inhibitors. These are certain antibiotics that say, hey, I'm pretty resistant to that enzyme, so why don't I just link up with the penicillin and I can help him to fight off this bacteria? Now, in general, these inhibitors are not really usually used on their own, because really the best thing they do is inhibit the beta-lactamase. So we see a lot of these combinations out where we work: Unicin, Augmentin, and Zosyn. These are all going to be penicillins with these beta-lactamase inhibitors. So ampicillin is going to be Unicin. Amoxicillin does become Augmentin. Piperacillin is Zosyn. So be very careful when you're prescribing these or looking at these. If your patient has an allergy to penicillin medication, make sure you're looking what is in Unicin, what is in Augmentin, what is in Zosyn. So in general, cephalosporins share that same kind of structure, that beta-lactamase, okay? And if bacteria is going to inhibit or become resistant to cephalosporins, we call these cephalosporinases, just like we call these penicillinases. So they're specifically going to break down the cephalosporins so they don't work as well. Now, cephalosporins, there's a ton. We have first generation all the way up to our fifth generation. And the idea here is as you go from first to fifth generation, three things happen. One, these cephalosporins increase activity against gram-negative bacteria. They also increase resistance against these beta-lactamases, so they're better at overall fighting off that bacteria that's trying to shut them down, and they increase their ability to reach the CSF. So obviously, if you have a patient with meningitis, for example, you'd want to use more of a fourth or fifth generation cephalosporin than a first. Cephalosporins, again, just good examples is cefalozolin or cefepime is another good example. And relatively, these medications start with Cef or Ceft, okay? So Cef or Ceft, and there's a ton of them. Now, these medications are commonly going to be IM or IV. There is about 10-ish that are PO, but you'll see these more likely to be IM or IV. Now, the most adverse reaction to our cephalosporins, like cefepime, is going to be allergic reactions, which again, we see again with penicillin as well. The cephalosporins, you can switch to a cephalosporin, like I said before, if your patient has a mild allergy to penicillin. Now, some of these also have very unique adverse reactions. I'm just trying to couple them all together. But obviously, if you're giving a certain cephalosporin, make sure you look at it and see. For instance, cefalozolin is not to be used with alcohol, which a lot of our other antibiotics kind of carry that risk too, like Flagyl. Now, when we look at carbapenems, which again are these beta-lactam antibiotics, we have meropenem and imipenem, and these guys are really good broad spectrum against gram-positive cocci, gram-negative cocci, and bacilli. They work again by weakening the cell wall and eventually causing lysis. So meropenem, one of the adverse reactions is GI effects. Vancomycin, a very unique antibiotic. Vancomycin is going to weaken the cell wall, which again leads to lysis, like all the other ones we've talked about. A little bit different here, but really the same idea. Now, vancomycin is usually, not always, but it can be reserved for certain kind of resistant bacteria, such as C. diff and MRSA, or it can be used secondary if a patient has possibly a penicillin allergy. Vancomycin, one of its largest adverse reactions or side effects is going to be renal failure. That's why sometimes you'll see that we're getting peak and trough levels of this medication in the hospital, especially if a patient has an acute kidney injury or any signs and symptoms of renal failure, because this medication directly can be nephrotoxic. Tetracyclines, such as tetracycline and doxycycline, they work by suppressing the growth suppressing growth of bacteria by actually inhibiting the protein synthesis. Now, some of the uses of tetracyclines are things like Rocky Mountain spotted fever, chlamydia, which we'll cover in another video, pneumonia, Lyme disease, anthrax, H. pylori, which we know is a common bacteria to cause issues with peptic ulcer disease, like duodenal ulcers and gastric ulcers, which we covered in another video. A lot of times we will give multiple antibiotics, therefore to reduce the instance of resistance of H. pylori, so possibly a tetracycline with flagyl and other antibiotic, and also giving a PPI and an H2RA as well. Now, some of the adverse reactions of tetracyclines, like doxycycline and tetracycline, are going to be GI disturbances. Now, that's a pretty common theme you're going to see with a lot of antibiotics, but you can always tell people sometimes to take with food, just depending on the antibiotics, because some of them, it'll actually decrease absorption of the antibiotic. Now, very specific to tetracyclines is the teeth and bone. What I mean by that is tetracyclines like to bind to calcium. And when they bind to this calcium, they can stain the teeth. Now, the good thing is this isn't usually a permanent staining of the teeth, but it is, or it can be permanent in children that are in the age of 4 months to 8 years. For that reason, we don't really use tetracyclines in kids less than 8 years of age. Now, some other things that can happen with tetracyclines are superinfections, hepatotoxicity, and renal toxicity. Tetracyclines can also form this non-absorbable chelates with calcium, iron, magnesium, and aluminum. Now, why does that matter for your patient? Well, anything that has calcium, like our dairy products, things that have magnesium, like some of our antacids, can, or laxatives, can bind with this tetracycline. We don't want that to happen. So in general, when we're giving tetracycline with any of these compounds, we want to wait at least an hour or two in between taking them because we don't want it to bind with the calcium, magnesium, aluminum, and iron. Macrolides are called this because they're larger. So this is your erythromycin, azithromycin, and clindamycin. Now, in general, what they do is they inhibit protein synthesis, which the bacteria needs to survive. Now, some of the uses are going to be chlamydia, and some of our different kinds of pneumonias. Some of the adverse reactions of erythromycin, azithromycin, and clindamycin, our macrolides, are going to be GI effects. Now, this is a good example. You can take these medications like azithromycin with food, but it might decrease the effects. However, it will help them with their GI side effects. The other thing is these can prolong QT. Next, we're going to look at sulfonamides, or just sulfa antibiotics. Now, these uses are really good for some of our UTIs because we know UTIs are commonly in the community caused by E. coli. Now, some of the adverse reactions to our sulfa drugs are hypersensitivity reactions like rash, fever, photosensitivity, increased risk for sunburn, and then also renal damage. So anytime we're giving a sulfa medication that starts with sulfa, we want them to drink a lot of fluid as well. Now, sulfa medications can be combined with other medications to give us Bactrim. Now, Bactrim is a common antibiotic we can see sometimes given for uncomplicated UTIs. Now, moving forward, as far as UTIs go, we know that UTIs are going to be more common with women. And that's because they have a shorter urethra, and there's actually closer proximity of the urethra to the anus, which we know that when we have relocation of this bacteria usually down there, like E. coli and staph, it increases the risk of having a UTI. Now, we know in the hospital we're going to look at different ones like Klebsiella and stuff like that, but these are the most common in the community. Now, as far as a UTI, the most common site we see this is cystitis, which we know is the bladder, so inflammation of the bladder. So acute cystitis, or inflamed bladder, is the most common site we're going to see UTI. Now, in general, when we're diagnosing a uncomplicated UTI, we're looking at bacteria in the urine. We're looking for leukocyte esterase and nitrite for ductase. Now, complicated UTIs can be a couple different things. Some of them are involved when people have abnormality in the urinary system or health problems that might suppress their actual immune defense, like HIV or diabetes. Now, pyelonephritis, which is a subset, I guess, of UTIs, is when that infection then inflames or infects any of the upper urinary tracts, one or any more than one. So the ureter, the renal pelvis, and the kidney all of those can then be inflamed, and we call that pyelo or pyelonephritis. Now, some people that are at risk for pyelonephritis are going to be patients that have kidney stones or pregnant patients, and some of the things we can see outside of ultrasound and stuff like that is white blood cell cast. As far as treatment, the most common we're going to see in the community, again, is E. coli and Staphylococcus. In the hospital, we can see Klebsiella and then Enterobacter. Now, with cystitis, you can give single-dose therapy or a short-course therapy, which is relatively 3 days. Now, the only way you can do these short-course or single-day therapy is if the UTI is uncomplicated, symptoms started within 7 days, and the patient's not pregnant. If that all goes out, then they are going to get more of the conventional 7-day treatment. Okay. Again, Bactrim is something we're going to see common, one of our sulfa antibiotics. Now, if we have pyelonephritis, mild to moderate, we're usually going to give, we can give Bactrim, but treatment's going to be longer than 7 days, up to 14 days. Again, with just normal cystitis, we can give urinary tract antiseptics. A good example of that is Macrobid. Macrobid is an antiseptic of the urinary tract, so it can help with lower urinary tract bacteria such as staph, strep, and then that common E. coli. It can also help out with recurrent UTIs as a prophylaxis against them. Now, recurrent UTIs can come from the same bacteria just regrowing or different bacteria coming in and colonizing. Now, adverse reactions of Macrobid are things like GI effects, common thing we see here with our antibiotics, so we can take it with food. Pulmonary reactions like chest pain, chills, fever, cough, peripheral neuropathy, and later stages of pregnancy, we don't want to give Macrobid. Now, when we look at fluoroquinolones, or just quinolones, those examples are going to be ciprofloxacin or Cipro, and levofloxacin or Levoquin. Okay. Now, the actions of these are going to inhibit DNA replication. Now, some of the uses are going to be infection of the respiratory tract, GU, GI, bones, and joints. Generally, we're not using these quinolones for patients above the age of 18. Okay. Now, we can if they maybe have complicated UTI or anthrax. And the reason we don't use quinolones or fluoroquinolones in people under 18 usually is it can cause tendon injury. So you really want to watch your patient for any signs of tendon pain, swelling, and you want to get rid of this medication. It can cause tendon rupture, commonly the Achilles tendon. It can also cause phototoxicity. So with Cipro and Levoquin, and these medications obviously are ending in fluoxetine. So with Cipro and Levoquin, we want to be careful giving these to patients under the age of 18. Now, our last is going to be our aminoglycosides, such as gentamicin and tobramycin. The biggest adverse reactions are going to be ototoxicity and nephrotoxicity. Again, that's all I have. Very quick, but we covered a lot. If you have any questions, leave a comment. Give me a like if you like this video, and I'll see you next time.